بسم الله الرحمن الرحيم. الله يعطيكم العافية جميعا. As Dr. Ghazi just mentioned that we are approaching the autumn and winter, which represent a big challenge actually, especially nowadays with the corona or the COVID-19 pandemic. So to avoid some mishap that might be happening during this winter and autumn, I will be talking quickly about the main approved anti-influenza antiviral. Actually, there are many anti-influenza that are used in different countries which are not approved by the FDA. So my talk today will be mainly about those which are approved. I will give a quick brief background about influenza. Then I will move to talking about the antivirals. As you all know, influenza virus affects around 10% of the world population yearly, and it might cause severe cases in up to 5 million people worldwide, with 650,000 deaths each year, especially in high-risk groups, such as pregnant women, children, and those with underlying chronic condition or immunosuppression, and elderly individuals above the age of 65. As per the guidelines. Actually, this slide is the simplest figure that I could find to give you an idea about the life cycle of the virus. It's necessary to have an idea so that we can understand the mechanism of each antiviral that I will be talking about. The influenza virus is an orthomyxovirus, which is enveloped and has a negative RNA genome. The structure of the virus has two important molecules on the surface that we call HA, hemagglutinin, and NA, neuraminidase. Hemagglutinin is necessary to attach to the receptor at the surface of the cell, and the receptor is sialic acid. So if you can block this attachment, you must succeed in treating or preventing the infection. After being internalized into the cell, the virus will be surrounded by a vesicle, as you can see in stage 2. This is endosomal vesicle, and due to acidity change inside the vesicle, the genetic material will be released by a step that we call uncoating. The virus will open due to acid change, and the genetic material will be released into the nucleus where transcription and replication will take place. Thereafter, the virus will assemble at the surface of the cell and then will be released by budding. So if you can inhibit any of these stages, you might succeed in treating or preventing the infection, as I just mentioned. There are some priority groups that you must use the anti-influenza therapeutics as soon as possible, such as the patient who is hospitalized, a patient who has severe complicated or progressive illness, a patient who is at higher risk of influenza complication. Start treatment as soon as possible without waiting for a laboratory confirmation in suspected cases among these groups. Now, what are the classes of anti-influenza antivirals? Actually, we have 3 main classes that are approved by the FDA. The first class is the neuraminidase inhibitor, and the second class is the K-dependent endonuclease inhibitor. The third class, which is now part of the history, actually, the admantins, which includes amantadine or rimantadine, they are not recommended to be used for treatment of influenza because of the high level of resistance, which approaching 100%, 99%. Resistance for these two antivirals approaching 100%. Then I will be talking about the next generation, the most significant next generation influenza therapeutics. Now, talking about the first family or the first class, neuraminidase inhibitor. They act by blocking the neuraminidase enzyme of the virus. This enzyme, if you remember the structure, we said we have hemagglutinin and neuraminidase. After the assembly of the virus on the surface of the cell, it needs to be released, but it will stuck with the sialic acid, the receptor, which is found on the surface of the cell. So the neuraminidase will act like a scissor. It will cut this attachment between the virus and the cell surface, leading to release of the virus. Now, neuraminidase inhibitors will inhibit the action of this molecule. By that, it will decrease the viral spread, so it will keep it attached to the cell. The highest clinical benefit from using neuraminidase inhibitors and in general all anti-influenza antivirals is when you use it within the first 48 hours, soonest as possible. It was found that neuraminidase inhibitors will reduce the length of illness by an average of 1.5 days, 1.5 days, and it will reduce also the severity of symptoms if used within a couple of days from the onset of symptoms. I will briefly talk about each anti-influenza within this family. The first one, I believe all of us are familiar with it, the oseltamivir phosphate, which is called Tamiflu, that we started to hear about during the pandemic, 2009 pandemic. It is available in capsules at a different concentrations, 75, 45, and 30 milligrams. And it is available also as oral suspension. So it is given orally. It is active against both influenza A and B. You know, we have 3 influenza viruses, A, B, and C. So this Tamiflu or oseltamivir is active against both influenza A and B, which are commonly circulating during autumn and winter. And it is recommended, it is the first drug that is recommended for patients with severe complicated or progressive illness, in patients who are not hospitalized, or amongst patients who are hospitalized, and for uncomplicated influenza. So nearly you can use it for all categories of infected patients. So it's a good choice, actually. Inhaled zanamivir is the second antiviral in this family, and it is called commercially, the name is Relenza. It is used by inhalation twice daily. However, there is a serious side effect that was noticed during the use of Relenza, which is severe and even might be fatal bronchospasm. So it is not recommended for either treatment or prophylaxis in influenza individuals with underlying airway diseases, such as asthma, COPD, and even in those who are allergic to lactose or milk protein because of this fatal side effect. The third neuraminidase inhibitor is peramivir, Rabivab, commercially known as Rabivab. It is indicated for the treatment of acute uncomplicated influenza in adults who have been symptomatic for no more than 2 days, i.e. within a couple of days from the onset of symptoms. It is given once daily, so the single dose anti-influenza. If the patient, it depends actually on the age of the patient. On those age 13 years and above, you can give the whole dose of 600 milligram intravenously over 15 to 30 minutes by infusion. If the patient is 2 to 12 years of age, and actually this recommendation is not by the FDA, it is a recommendation that was issued by the American Association of Pediatricians using peramivir in children below the age of 13. Well, if you use it in this category, you will dose it according to the weight of the patient. You give one dose of 12 milligram per kilogram once daily if the patient is below the age of 12 years. Now moving to the second category of anti-influenza therapeutics, that is the cap-dependent endonuclease inhibitor. In this category, you have only one antiviral, which is Baloxavir, marboxil, known as sulfluza, commercially. Again, it is active against both influenza A and B viruses, so it's a good option or a good choice to use during the winter or autumn season. It acts by interfering with the viral transcription and replication. It is approved by the FDA for the treatment of acute uncomplicated influenza in people older than 12 years who are otherwise healthy or at high risk of developing influenza-associated complications. Actually, there are no available data for using Baloxavir in pregnant women, immunocompromised people, and in people with severe influenza. The clinical trials were done or were carried out among the healthy or those at high risk group, but not among pregnant women or immunocompromised. Again, the dose is a once daily dose, prophylaxis. If the patient is below the age of 12 years, then you will give the dose based on the weight. That's the weight is less than 80 kilograms, then you give just 40 milligram once daily. And if the patient is 80 kilogram or more, regardless of the age, you give the whole dose of 80 milligram. Advantages, as I just mentioned, or as I mentioned at the beginning of my talk, actually they act by blocking the M2 channel protein, inhibiting the release of the virus from the endosomal vesicle. So the virus will be stuck inside this vesicle and will not be able to replicate itself within the cell. However, due to high rate of resistance, it is not now recommended for treatment of influenza. The last part of my talk will be about the next generation influenza therapeutics, unapproved antivirals. Actually, they are under clinical trials for their effect against influenza. They are some of them are antivirals that they do exist, but they are trialing them for a different usage, as I will mention some of them in the next few slides. The first one is zanamivir octanoate. This one is a neuraminidase inhibitor, and it has been approved in Japan since, I believe, 2015 for influenza A and B, for prophylaxis and treatment, but it has not been approved by the FDA yet. It is used as inhaled single dose anti-influenza. Another one which is under investigation actually is the EIDD 2801. It's not yet been given a name. It is a cysteine ribonucleoside analog that inhibits the viral transcription and replication. It works at this stage, transcription and replication. It is given orally, and it has an expanded spectrum, not only against influenza virus. It proved that it has effect against other RNA viruses such as flaviviruses, coronaviruses during the trials. The third one, by Mutah University, it inhibits the viral polymerase PP2 subunit, and it has a very low resistance rate as shown by the clinical trials in vitro. So this is promising coming anti-influenza therapeutic. This table actually summarizes the use of the commonly approved antivirals. As you can see, oseltamivir and zanamivir are the only two anti-influenza that can be used for treatment and chemoprophylaxis at the same time, while peramivir and bronchospasm are used only for treatment. They're not approved for chemoprophylaxis. So this table shows the usage of each antiviral and the age, and if there is any contraindications or serious side effects, like, for example, Relenza or zanamivir, its association with the fatal bronchospasm. And this table, it shows the dosage of each anti-influenza medication or therapeutic in case that you want to use it for treatment or for chemoprophylaxis. If you are interested in having more details, this will show, this table will help you in knowing the dose, the duration of each anti-influenza. And I believe this is the last slide. So that was a quick review of anti-influenza therapeutics that we are currently having and we can use during the next coming season. Very important note, having an influenza virus conferred by diagnosis does not exclude that the patient might be having coronavirus. So If you have a positive test for influenza, this does not preclude the presence of COVID or corona, MERS-CoV-2, and the vice versa. There might be co-infection as per the new studies that have been published. Thank you. Thanks a lot.